Hello everyone, this is Dr. Singaram. Welcome to the discussion of pediatrics question which were asked in this January 2023 FMG exam. Coming to the number of questions in pediatrics, there were around 18 questions in pediatrics. Of course, few are integrated questions with the other subjects as well, but around 18 questions were there. Okay, coming to the topics which are asked in the pediatrics part, it was a standard and expected topics only. Of course, one or two questions which were outside the usual pattern of FMG questions, but of course that is expected for any examination. So let us start a discussion of the questions and the answers which were asked in this exam. Before I start the discussion, these are all recall based questions, so the accuracy of the questions may not be fully correct. You are welcome to modify or add any missing questions in the comment section below the video. Let's start with the first question. During neonatal resuscitation of a term baby, how much percentage of FiO2 will you require? Okay, this question is about resuscitation where they're asking percentage of FiO2. It means the concentration of oxygen which is required during resuscitation, and the key word here is the term baby. That is the important word here. Okay, so this answer is from the guidelines only, where the guidelines clearly say that it is room air. What is room air? Room air is nothing but 21 percentage of oxygen. That is all which is required for oxygen during resuscitation in a term baby. If you go by the guidelines, this is what it is. PPV, that is positive pressure ventilation, is initiated with 21 percentage oxygen or room air in case of term babies and late preterm babies. Okay, late preterm is something like 35 or 36 weeks of gestation. Okay, for those two groups it is room air which is recommended, and for other preterm babies it is 30 percentage of oxygen, means you have to additionally give supplemental oxygen. This is what is the guideline. So depending on whether it is term or preterm, you have to answer accordingly. And once you have started oxygen therapy, you have to monitor whether that oxygen therapy is adequate or not, and that monitoring is done by oximetry, which is nothing but pulse oximetry, where we measure SpO2, that is oxygen saturation, which will be a guide once we start oxygen therapy in these babies. Okay, so this is about the first question. There was one more question about neonatal resuscitation. It's a pretty straightforward question. During neonatal resuscitation, at which stage chest compression should be given? Okay, this is again based on the guidelines only. Straight away telling you the answer. For initiating chest compression, the heart rate should be less than 60 per minute. So option C is the answer. This is very different from the resuscitation in the other age groups where heart rate is nil or there is no pulse, you will start chest compression. But for newborn babies, it is heart rate less than 60 per minute. This is the same summary of neonatal resuscitation algorithm which I used to share in the regular classes. This is a quick recap of the same. Okay, and during resuscitation, when the baby is not crying, you have to start the initial steps of the resuscitation, which includes warmth, okay, positioning the baby, as well as clearing the suctions, clearing the secretion if there are any anything which you can see, and one more is providing warmth to the baby. All these are the initial steps of resuscitation. And after the initial steps, of course the initial steps would also include the tactile stimulation also. If after the initial steps the baby is not crying, then you have to assess the heart rate. And here heart rate is very important. If the heart rate is less than 100, you have to start PPV, which is positive pressure ventilation. Typically positive pressure ventilation is given by either bag and mask ventilation or endotracheal tube insertion and then ventilation. Okay, and after PPV, if the heart rate is less than 60, then you have to start chest compression. And this is exactly where the question has been asked. At what heart rate you will start chest compression? It is heart rate less than 60. Even after chest compression also there is no response, you have to give adrenaline as the last step in neonatal resuscitation. This is what is the exact guidelines have to say. If the heart rate remains less than 60, even after starting 30 minutes of positive pressure ventilation, you have to start chest compression. And here is the important point. Chest compression should not be given alone. Compression should be combined with ventilation. Typically 90 compressions and 30 inflations or ventilation, which is simplified and remembered as 3:1. Can you see that? 3:1. 90, 30 simplified as 3:1. So the ratio, it is again an important previous year question, 3:1 ratio, which is what is compression ventilation ratio. Okay, and one more question is, how do you provide chest compression? What is required is a two-thumb technique is preferred. All these are previous year questions which you should remember regarding chest compression. Moving on to the next question. In a child presenting with short stature, bone age was found to be corresponding to the chronological age. Means bone age is equal to the chronological age. If I represent bone age as BA and chronological age as CA, it is BA equal to CA. That is what is the question telling you. Okay, and if you can remember from the classes, in every child with short stature, we try to compare the bone age with chronological age, and that is what is given here also. Moving on to the next line, child's height is comparable with the parent's height record. This is again a very important clue. The child's height pattern is corresponding to parent's height record also. Okay, right. So what is the likely condition? There were many options, okay, like familial short stature, constitutional delay, some hormonal disturbances and all. This pattern is fitting into familial short stature. What are the clues for familial short stature in the question? Number one clue was bone age corresponding to chronological age. It's a very important clue. Second important clue is height is comparable with the parent's height record, telling that it's a normal variant of short stature. Usually there are two normal variants of short stature. One is familial short stature, another one is constitutional delay. How do you differentiate? It is based on this point only. If the bone age is equal to the chronological age, then it is familial short stature. If the bone age is less than the chronological age, it is constitutional delay. What is the meaning of less? Bone age is delayed. That is what is the meaning of less than the chronological age. That is seen in constitutional delay. The clue is from the name itself. What is that? Constitutional delay. So you can easily remember bone age is delayed. Okay. In this question, it was very clearly given bone age equal to chronological age. So the answer is familial short stature. Moving on to the next question. Okay, this has been already discussed. Moving on to the next question. Just a minute, I'll take up that question. This question is asking a child who is having severe acute malnutrition. So this is a scenario wherein it is not any other child but a child with SAM or severe acute malnutrition. That child has presented to the emergency in a state of shock. So a SAM child is having shock. Usually the reason for shock is due to dehydration associated shock in these children. Which of the following is preferred fluid initially in this particular baby? Okay, ringer lactate plus 5% dextrose, normal saline and hypertonic saline. Now, if you want to answer this question, you have to know few things. One is, what are the key abnormalities in a child with SAM? Okay, number one and very important is the hypoglycemia. Okay, and hypoglycemia is defined as blood sugars less than 54 milligram per deciliter. This is a very important abnormality which you encounter in a child with SAM. The second set of abnormalities is related to the electrolyte imbalances, which includes hypokalemia, hypomagnesemia, and one more very important would be high total body sodium. So the level of sodium in this particular child is always high. Now, if you have these abnormalities in your mind, you can easily tell what is the answer for this particular question. Again, I will take you back to that question. Just think for a moment based on the information I have provided and tell what is the answer. Okay. See, you have to give a fluid which is containing sugars or dextrose. Why? Because this child is always at risk of hypoglycemia. Number one. Number two, you need to give a fluid which has got relatively lesser sodium content because this child already has high total body sodium. And second thing, you have to give a fluid, okay, which will contain additional potassium because this child has a very important complication as hypokalemia. Now, taking you back to the question, which is the answer? Yes, I think you should have known by this time. Okay, at least you should have made up your mind whether it is ringer lactate or NS, which is normal saline. Okay, for this to be answered again, have a quick comparison between NS and LR. LR is nothing but ringer lactate or lactated ringer. Okay, if you see, look at the composition. Okay, I told you we need to have a fluid which is containing additional potassium. Which is that fluid which is having additional potassium? Of course, it is ringer lactate. Second, we need to have a fluid which contains relatively lower sodium. So if you compare, again ringer lactate has a lesser sodium compared to normal saline. So what should be the best answer for the question? it should be ringer lactate plus 5% dextrose. Don't forget why plus 5% dextrose, because these children are always at risk of hypoglycemia. Simple. Okay. Moving on to the next question. During initial assessment of an unconscious pediatric patient, A, B, C, D includes all of the following except. This is a repeat question from your previous exam. Okay, it's a straightforward question. Airways included for A, B for breathing, C for circulation, and D is not for diarrhea, and D is for disability. Okay, and it usually refers to the neurological disability that the child is having. Okay, right. Now this is taken from something called primary ACLS survey, which is nothing but advanced cardiac life support. Okay, what we call it as primary survey includes the basic things which we need to assess, which is remembered as A, B, C, D, and E. And for this question I told you, D is for disability, which is a neurological impairment in that particular patient. Okay, and one more thing additionally you have to remember is E. V is the exposure, means once you expose the patient, you see for something like evidence of trauma, injuries like that. That is what is the exposure meaning. Okay, now one more point also you need to know about this D, disability or neurological assessment. Basically we assess the consciousness, orientation or the size of the pupils in a patient at the time of assessing the D or the disability. And in this particular aspect you also need to know one more thing. For quick assessment of neurological impairment, what is that? AVPU. What is that? A stands for the patient who is fully alert. Of course, he is alert but may not be fully oriented. That is one thing. Then V is for voice. That means he is responding only to voice, not fully alert. Okay. P is he is responding only to painful stimulus, and U is unresponsive. This is a quick way by which we can assess the neurological impairment. Maybe your future question also. Okay. Should make a note of it. Moving on to the next question. A 15-year-old male child with a history of preceding URI, that is upper respiratory infection, is presenting with hematuria. Some said it was a cola-colored urine. Of course, it's hematuria only. Investigation revealed significant hematuria with anti-DNase B positivity. This is an important clue. Okay. Based on this itself, we can say what is the diagnosis. What is the answer for the question? It is PSGN, which is post-streptococcal glomerulonephritis. Important clues of post-streptococcal glomerulonephritis. One I told you is anti-DNase B. Anti-DNase B is one of the antibodies which will be elevated following a streptococcal infection. Okay, the usual antibody which we study for post-streptococcal condition is ASO. What is that? Anti-streptolysin O. The levels will be elevated. That is true, but the alternate antibody is anti-DNase B, which is what was given in this question. Second important clue is a history of preceding URI. Usually 1 to 2 weeks back, that means before the hematuria starts, 1 to 2 weeks back, there would be a history of upper respiratory infection, typically in the form of sore throat or pharyngitis. The third important clue in the question is the age of the child. What is that? 15 years old. Okay. Typically, post-streptococcal conditions occur in a school-going child, which is typically in the age range of 5 to 15 years. Okay, so all this very clearly tell you that it is a post-streptococcal glomerulonephritis. A very typical question again. One more is a question which is repeat from your previous exams. In a child with malnutrition and following presentation, which is the likely cause? Okay, now this is a very typical case of Kwashiorkor. Why I am saying Kwashiorkor? Because this child is having edema. Okay, and typically you can notice that edema in the abdomen, which is nothing but due to ascites, or what is commonly referred to as the pot belly appearance. Okay, and this clearly tells that in a setting of malnutrition, it is Kwashiorkor. The main reason is presence of edema, and we know that now the answer is very clear. The Kwashiorkor, there is insufficient protein intake. Okay, please remember the other one, which is marasmus, is characterized by insufficient calorie intake predominantly. Okay, so this is a very straightforward and a previous year question. Answer is Kwashiorkor, so insufficient protein intake is the answer. Next was like a spotter question where they asked you to identify this abnormality. It's a very typical where you can see the legs are spreading apart, okay, and the knees are almost touching each other. What do you call it as? Knock knees. Okay, so many options were given: genu valgum, genu varus, okay, windswept deformity. What is this? This is nothing but genu valgum. Okay, valgum deformity. That is what you need to remember. Because it's a lateral deviation, so it's called valgum. If it is a medial deviation, which is the bowing of the legs, then it is called genu varus deformity. Okay, right. This is a very straightforward Potter question. Moving on to the next one. A 5-year-old child is presenting with heavy proteinuria. Electron microscopy of the renal biopsy specimen reveals loss of food process, and the child underwent treatment with steroids. What is the likely pathology? Okay, this is again a repeat question. They cannot give you a very a clear clue for this particular condition. You don't even need options for this. It's a very straightforward question. What is the answer? Yes, it is the commonest cause of heavy proteinuria, which is the feature of nephrotic syndrome. Yes, what is the answer? It is MCD, or minimal change disease. Very straightforward question. There are so many clues given in the question. What are they? One is the age of the child. Typically, you can see here it is 5 years, correct? What is the typical age for MCD? It is 2 to 6 years. Number one. Number two, electron microscopy finding. What is that? Loss of food process. This is very characteristic. Okay, if they have given this clue, there is no diagnosis other than minimal change disease. Okay, and third thing is treatment with steroid. Always remember, a child with a minimal change disease shows an excellent response to steroid treatment. Okay, all this very clearly tells it is minimal change disease. This is again one of your previous and a repeat question. Okay, moving on to the next question. An adolescent male has a history of weakness in the limbs and difficulty in getting up from the sitting posture. See, there may be so many causes of weakness in the limbs, okay? But when they are giving a clue like this, difficulty in getting up from the sitting posture, this is actually one of the signs. Can any of you pick up the sign? What is the name of that sign? Difficulty in getting up from this sitting posture. It's called Gover's sign. Gover's sign, which is a feature of proximal muscle weakness. Proximal muscle weakness. Okay. And the next line of the question, what is it? Family history of similar weakness is present. That means it's an inherited condition. So which is the commonest inherited condition characterized by proximal muscle weakness in a child? Yes, it is. Suppose I give you one more clue. It is usually seen only in males. That is, only males are affected by this condition. And try to correlate with the inherited. What is that pattern of inheritance? Yes, X-linked recessive pattern of inheritance. Okay, right. So, what should be the diagnosis we are dealing with here? It is nothing other than Duchenne muscular dystrophy. And what is the defect in this condition? It's a dystrophin gene defect. That was the answer for this particular question. It's again one of the previous year repeat questions. Moving on to the next one. In a neonate presenting with it is fully respiratory distress, the following X-ray finding is noted. What is the likely diagnosis? This is again, so many times we have discussed this in the classes, okay, and I keep repeatedly telling that it is one of the important X-rays. What can you see in the X-ray? Very classical. Can you see this? This is the nasogastric tube, which is supposed to be coiling in the upper part of the esophagus itself like this. Okay, very classical coiling of nasogastric tube in the proximal part of the esophagus. So among the options provided, which is the answer? Is it CDH? No. Is it RDS? No. RDS is characterized by whiteout appearance of the lungs. Is it esophageal atresia? Yes, that is the answer. Due to the atresia, the nasogastric tube gets coiled in the proximal part of the esophagus itself. Very clear diagnosis. Okay, right. Next one. Breastfeeding is absolutely contraindicated in. This is again a question which was asked in, I think, December 2021 exam. That exact repeat question was asked. Which is an absolute contraindication? It's a straightforward answer actually. It is galactosemia. Okay, I told this very clearly. There are two conditions in the baby which are absolute contraindications for breastfeeding. One is galactosemia, another one is congenital lactose intolerance. Okay, right. So answer for this question is again straightforward. It is galactosemia. Moving on to the next question. In idiopathic hypertrophic pyloric stenosis, or remembered in the short form as IHPS, all are true except. Okay, all of you know pyloric stenosis is a condition characterized by narrowing at the gastric outlet due to hypertrophy of the pyloric muscles. We all know about it, which is a false statement. That is what you need to pick up. Ultrasound is a sensitive investigation. It's a very true statement. In fact, the best investigation for diagnosing IHPS itself is USG only. Non-bilious vomiting, of course, yes, bile has not even entered in the stomach area, so it is going to be non-bilious vomiting only. Metabolic alkalosis, of course, it's a correct statement. Okay, why? Because during pyloric stenosis, the baby tends to vomit out the milk along with the contents of the stomach. The content of the stomach is a hydrochloric acid. So when the acid goes out, obviously you will get metabolic alkalosis. Okay, to be very to give you a complete electrolyte abnormality, it is hypokalemic, hypochloremic metabolic alkalosis. Anyway, that's a true statement. So what is the answer for the question? Automatically it is the last option. What is that? Hypertrophy of the longitudinal pyloric muscle. It is not longitudinal, it is circular muscle fiber hypertrophy. Okay, very very important. Okay, hypertrophy of circular muscle fibers, and that is the answer for this particular question. Moving on to the next one. An adolescent male child is presenting with intermittent jaundice. Investigation revealed mild increase in, this is the keyword, unconjugated bilirubin. Mild increase in unconjugated bilirubin with normal liver enzyme. That means ALT, AST are all normal. Now, first thing and the important clue in this question is increase in unconjugated bilirubin. Okay, this itself will help you to rule out two options in this question. What are they? Dubin-Johnson and Rotar syndrome. Why? In both these conditions, there is increased conjugated bilirubin, right? It's so straightforward, you can rule out those two options. Okay, the other options, Gilbert and Crigler-Najjar syndrome, both are characterized by increased unconjugated bilirubin only. But the point about Crigler-Najjar syndrome itself, it's a very, very severe condition. Especially in type 1, there is complete absence of UDP GT, which causes jaundice starting in the neonatal period itself, and most of the times it's a fatal condition. So it cannot be the answer, because this is an adolescent male having intermittent jaundice, means like a very mild form of jaundice only. So you don't expect Crigler-Najjar syndrome as a diagnosis here. So all the other options are ruled out. Answer for this question is Gilbert syndrome, which is very, very typically characterized by increased unconjugated bilirubin and late onset. That is why, can you see in the question, it is adolescent male child who is present. It is not a very young child who is presenting. Okay, little older child or adolescent is presenting, and also it's a benign condition. That is why in between only or intermittently only you get jaundice. Number one. Number two, there is only a mild increase in unconjugated bilirubin. With these 2 points, you can very clearly point to the diagnosis of Gilbert syndrome, which is the answer here. Next one, standard question, repeat question also, very straightforward. What is that? In a child with a chronic liver disease and neurological dysfunction, following findings are noted. This condition is due to accumulation of. First of all, we'll see what is this. This is actually pointing to something like this ring-like appearance at the edges of the cornea. More like with the slit lamp examination, you are able to see. You can also see this brownish colored area here. It's a ring-like area here, and also some form of cataract. Can you see that? There is some form of cataract also present. So which condition you will have cataract along with the brownish ring at the edges of the cornea or the limbus of the cornea? What is that? Yes, it is the KF ring, which is what is depicted here. And second is a characteristic cataract called sunflower cataract. So which condition is this? Very correct. This is Wilson's disease. This is a Wilson disease. I think this most of you should have got it correct. It's a very typical question. Wilson disease, you know, that affects the liver. So that is why these children have chronic liver disease. And also it can affect the brain, especially the basal ganglia. That is why they have neurological dysfunction also. So now the question is, it is due to accumulation of what? Very good. It is copper accumulation, and that too increased levels of free copper, or what is called as the toxic copper. So this was Wilson disease. Very, very clear diagnosis. Moving on to the last question. In a child presenting with a fever and history of watering of the eyes, conjunctivitis, rhinorrhea or coryza, both is nothing but increased secretions from the nose or running nose only. Also having cough, and now the following finding was noted. What can you see in that picture? This is very classically rash, and that too maculopapular rash. Maculopapular rash. Can you see very characteristically the rash is starting in the face area? Okay, right? It is very densely located rash, so that when you see that particular child, it is full of rash only. Okay, right? So which condition out of these presents with a fever, something like the initial symptoms like conjunctivitis, cough, coryza, what we call it as typically 3 C's, and along with that this characteristic rash? Which condition, right? It is a typical case of measles infection. Okay, that is the condition which usually presents like this. Okay, if you look at the other options, mumps will not present with the rash, so that is automatically out. In chickenpox, the type of rash is not maculopapular, it is a vesicular rash. I think all of you should know this, and so that is also out. Okay, meningococcemia, the child will be very sick looking. Okay, right, of course there will be rash, but the typical type of rash is something which is little bigger in size, called as the purpura fulminans. Okay, purpura fulminans. Okay, right, child would be very sick looking there, so that option is out. So automatically this is a case of measles infection which was asked in this particular exam. So that completes our discussion of the pediatrics recall question in January 2023 exam, and this question suggests the pattern which is moving towards clinical scenario type. And also I would want to tell that stick to the usual topics, don't try to read very extensively or very rare topics. They're not usually asked for the exam, especially at the FMG exam level. So stick to the usual topics, stick to your usual notes. You should be able to get through the questions with ease. Okay, I wish you all the best for the results. If you like this video, please share it with your friends, like this video, and if you have any comments, please put it up in the comment section below. Thank you, and I will see you in the next video soon.